The current approach to help. Unfortunately, most people with anxiety or depressive disorders remain untreated. A 2001 UCLA study showed that fewer than 1/3 of people suffering from anxiety and depression receive proper medical treatment. Although 83% of study participants reported that they had seen a healthcare provider for a medical condition within the previous year, only 30% had received adequate mental health care. Furthermore, only 19% of patients who had seen a primary care physician rather than a mental health specialist had received appropriate treatment for anxiety or depression. The treatment shortfalls were especially striking for African Americans, the elderly, the young, and those with less than a high school education. The embarrassment, shame, and stigma associated with having a mental illness often prevent people from seeking help. Because we were unable to visualize brain problems, many people felt as though their behaviors and bad feelings were in some way the result of sin, a failure of will, a character flaw, or were simply made up. Understandably, then, they were ashamed of their problems and reluctant to seek help. When people with anxiety or depressive disorders are brave enough to seek help, typically from a primary care physician, most receive medication as the only intervention. The era of managed care has forced primary care physicians to treat illnesses for which they have less than adequate training. These well-meaning doctors often take a simplistic approach to anxiety and depression, assuming that one treatment fits all, which leads to many treatment failures. Usually, medication-only treatment for these disorders is bad treatment. While the right type of psychotherapy from a skilled therapist can be very helpful in alleviating the pain of anxiety and depression, knowing how to select the right type of psychotherapy and when to apply it can be confusing. It is estimated that there are hundreds of different kinds of psychotherapies, offered by a wide variety of clinicians, including psychiatrists, psychologists, marriage and family counselors, social workers, pastoral counselors, psychiatric nurse practitioners, hypnotherapists, and so on. Also, when patients with underlying brain problems engage in psychotherapy as the sole treatment for anxiety and depression, failure and frustration are common. The treatment outcome improves if patients see a well-trained psychiatrist. Over the last 15 years, a host of new medications has become available for effective treatment. Additionally, psychiatrists also know when to refer their patients to psychologists for effective psychotherapy, so that they get the benefit of medication and therapy. Yet the high incidence of overlapping illnesses leads to many treatment failures, even when care is from well-trained psychiatrists. Many of the new patients we see at the Amen clinics come to us taking 2, 3, 4, or even 5 different medications, and they have seen a number of different psychiatrists and therapists. A new approach. A more sophisticated, comprehensive approach is necessary for treating anxiety and depression. The new approach needs to take the following into consideration. Anxiety and depression commonly occur together. These illnesses are, in large part, the result of brain dysfunction. There are specific types of these illnesses, and there are a number of effective treatments that are specific to each type. A major problem with the current approach to mental health treatment is that psychiatrists and others treating mental disorders never look at brain function. Psychiatrists are the only medical specialists who never look at the organ they treat. The lack of brain imaging has kept psychiatry behind medicine's other specialties, decreasing our effectiveness with patients and reinforcing mental illness stigma and non-compliance with needed treatment. Odds are, if patients are having serious problems with their feelings, depression, thoughts, intrusive, frightening ones, or behavior, aggressive or self-destructive, the treating physician will not order a brain scan. He will prescribe psychotherapy or powerful combinations of medications without ever looking at how a specific patient's brain works. He will not know which areas of his patient's brain work well which work too hard or which do not work hard enough. This is the equivalent of orthopedic doctors setting broken bones without x-rays, cardiologists diagnosing coronary artery blockages without doing angiograms or fast CT scans, or internists diagnosing pneumonia without ordering chest x-rays or doing sputum cultures. Yet the state of the art in psychiatry is to not look at the organ it treats. Essentially, the diagnostic practices of psychiatrists have not changed for 150 years. Because the right treatment optimizes brain function, giving a person more access to his or her own abilities, and the wrong treatment makes things worse and demoralizes patients and families. It's time to start looking at the brains of individual patients. Typing anxiety and depressive disorders based on brain dysfunction will be one of the next major movements in psychiatry. It will help us stop blaming difficult behavior on misguided will and lead us to consider and optimize the brain. Typing anxiety and depression. At the Amen clinics, we have discovered that anxiety and depression are a diverse group of brain problems that require individualized prescriptions. The Amen clinics have pioneered the use of brain imaging techniques in clinical practice, and we currently have the world's largest brain imaging database for psychiatric indications, totaling more than 17,000 scans. Based on our research with thousands of patients using brain SPECT imaging, one of medicine's most sophisticated functional brain imaging studies, we have been able to see the major anxiety and depression centers in the brain. Our research shows that anxiety and depression are real, brain-based, and fall into 7 different categories: pure anxiety, pure depression, mixed anxiety and depression, overfocused anxiety/depression, cyclic anxiety/depression, temporal lobe anxiety/depression, and unfocused anxiety/depression. Seeing the initial SPECT studies on our own patients dramatically changed our perceptions of mental illness. Looking at the brains of people who suffered from emotional illnesses helped us begin to understand the unique patterns underlying their illness and the tendency of these patterns to improve with treatment. We were, and continue to be, dumbfounded at the strong resistance by many physicians toward using brain imaging tools in clinical, neurological, and psychiatric practice to evaluate serious behavioral or emotional problems. Many physicians who resist progress and the use of technology say tendencies toward specific psychiatric illnesses in brain scans cannot be seen. The scans are overinterpreted. It is too soon to use brain imaging tools on patients, even though they have been available for more than a decade. And more research is needed before brain imaging can become a clinical tool. Psychiatrists must look at the brain if we are to understand the problems we face. One of the criticisms of using brain imaging in clinical practice is that not enough published literature exists to verify its helpfulness. Yet there is a large volume of literature on brain imaging for behavioral problems. Psychiatric journals frequently feature imaging articles. Unfortunately, too few psychiatrists take the time to integrate the information. On our website, www.brainplace.com, you can see more than 500 abstracts on brain imaging for neuropsychiatric reasons. We should image the brain in people who struggle with thoughts, feelings, or behaviors, because the brain is complex and needs to be better understood. We need more accurate diagnostic tools and more precise treatments specific to the areas of the brain involved in particular illnesses. This audio program is a practical guide to conquering anxiety and depression based on new brain science. We are able to do this based on our extensive brain imaging database and clinical experience.